Welcome back to Pete Script. I'm Zach Hodges.
And I'm Al Shanklin. Today, we have a big episode and a big guest. We are talking to Dr. Sapna Kudchadkar about how she sedates her toddlers.
Yes, Dr. Sapna Kudchadkar is an anesthesiologist-in-chief at Johns Hopkins Children's Center and vice chair for pediatric anesthesiology and critical care medicine at Johns Hopkins University School of Medicine. In addition to this leadership role, she's the lead PI for a multi-center randomized controlled trial of the multifaceted early mobility program for critically ill children, the PICU Up study, and a co-PI for the NIH-funded multi-center randomized trial investigating physical rehabilitation and nutrition in pediatric ICU patients, the Proximus study. Dr. Sapna Kudchadkar started her career at the University of Chicago Pritzker School of Medicine, where she earned her MD. She then completed residencies in both general pediatrics and anesthesiology at Johns Hopkins Children's Center and the Johns Hopkins Hospital, followed by clinical fellowships in pediatric critical care and pediatric anesthesiology at Johns Hopkins. In addition to this robust clinical training, Dr. Kudchadkar received her Ph.D. in clinical investigation at Johns Hopkins Bloomberg School of Public Health. We are so excited to be talking with her today.
Yes, this episode is the expert opinion. We could not wait to ask her exactly how she sedates her patients and what she's doing clinically to prevent delirium.
Yes, fascinating topic. It's something that we deal with every day in the pediatric ICU, from sedating these toddlers to preventing delirium, treating delirium. So many learning points that I've taken away from today's conversation. We're so excited to share it with you.
Dr. Kudchadkar, thank you so much for joining us today. We've given your intro up front, of course, but can you tell your listeners who you are and something that you enjoy outside of medicine?
Oh, absolutely. Thanks for having me, guys. I'm Sapna Kudchadkar. I'm the Anesthesiologist-in-Chief at the Johns Hopkins Children's Center and the Vice Chair for Pediatric ACCM. When I'm at work, I do a combination of pediatric intensive care and pediatric anesthesiology. And a little bit about me, I grew up in Southern Illinois and was a Midwestern girl until I moved to the East Coast to be with my husband. And something interesting about me that people may not know is that I am an avid trumpet player. So I've played trumpet since fifth grade, and I still play. And I have a son and a daughter who are also trumpet players as well.
That's amazing.
That's so fun.
And we're so happy to have you here.
Thank you. It's good to be here.
Before we jump into today's topic, any conflicts of interest related to this conversation that you need to disclose?
No specific conflicts of interest. Of course, I have NIH funding relevant to PICU Up trial and the early mobilization work that I do, but that's the main thing to mention.
All right. Well, let's get things started. We're going to start off with a clinical case, and we are so excited to hear how you would sedate this patient, prevent delirium, maybe even mobilize them.
Cool. Let's do it.
All right. So we've got a 2-year-old previously healthy girl who was recently intubated for hypoxemic respiratory failure secondary to influenza A with a superimposed pneumonia. You've just put the tube in. She is on a PEEP of 8 requiring 70% FiO2, and you ask your resident to order some sedative infusions while you wait at bedside for a confirmatory X-ray. So to get things started here, we've just intubated this 2-year-old. What are your first line agents and how sedated do you want this patient?
Great questions. And absolutely the first thing. So one thing I find is that our PICU culture has typically, and that's what inspired me to do all of the work that we're going to talk about today, we often set kind of a standard for every single patient. And basically we need children to be automatically sedated, whatever that means, and we'll define that as soon as a breathing tube goes in. So in this child's case, not knowing much about their medical history other than probably relatively previously healthy, has a new pneumonia, and obviously a terrible event for the family, stressful, etc., a lot to deal with, is to take a step back and say, okay, we gave medications to do a safe intubation. And so what's next? Is this a patient that we can talk to the family about the importance of delirium prevention, what delirium is, and how we would like to keep their child as wakeful as possible and safe in order to prevent delirium and optimize pain first and foremost. The analgesia is the first line thing to do, and sedation if needed. And that's kind of my mantra when I talk to trainees, including residents and fellows. What do we want to accomplish? What is our state behavioral score goal here? And as long as you're using a validated sedation tool in your unit to assess that, that's the most important thing. So we use the SBS. Many units use the RASS. In Europe, the comfort scale is very common. I think those three are the primary tools that are used across the world. child. So what is your SBS goal? And I think that's where you're getting at, is how do we set an SBS goal for this patient? Well, a 2-year-old is challenging. There's no question, right? Because they are starting to understand what's going on, what's happening, and you can maybe start to talk them through, but they're going to wake up for their intubation medications and be scared. There's no question. They are not going to understand what's going on, but then potentially their family members and you can help to orient them and see what they need. And then the key is start low and go slow. So the default should always be an SBS of 0 unless otherwise needed. Now, and you guys can interrupt me at any point. Now, if there's a issue with oxygenation that requires the child to be completely sedated and not participatory with the ventilator, then you might aim for an SBS of -2, right? But if the patient could potentially have some spontaneous ventilation without hypoxemia, then an SBS of 0 to -1 is completely reasonable. But the key is not to commit the child to a deep level of sedation until you've proven that an SBS of 0 to -1 won't work.
Interesting. And for our listeners who maybe you're newer to the PICU, what would a patient look like who's SBS 0 or SBS -1?
Right. SBS of 0 is essentially calm, can be aroused very easily, able to follow commands if they're old enough to do so, and essentially just a calm and comfortable patient that will open their eyes spontaneously, look around, and have attention. And then in contrast, an SBS of -1 is they're probably there with their eyes closed most of the time, but they are still arousable with stimulation, but may or may not be consistently following commands. And then a positive one is kind of the opposite of that, which is they're not unsafe to themselves or others. However, they might be on the verge and are agitated, but they still, and again, this is separate from delirium, they still are attentive to you when you try to redirect them.
Nice.
Great question.
So what at the Johns Hopkins Children's Center, I know that every PICU has different supplies of different
Sure.
things, but what medications are you ordering with to start and what are your starting doses?
Absolutely. So the first and foremost, as you mentioned, it's always analgo sedation, but focusing on the analgo first, right? So at our institution, we don't have a sedation protocol, actually. There is some work being done to establish a nurse-driven sedation protocol, but we've done just fine without. So if you're listening out there and you don't have a sedation protocol, don't assume that you can't impact culture, start to change your practice if you don't have a protocol. That's not necessarily the first step, although protocols do help with streamlining practice and having more consistency. So if I were the attending at the bedside, and there's some variability between obviously the attendings even at Johns Hopkins Medicine, I would suggest to the resident that they order a morphine infusion for this 2-year-old in addition to a dexmedetomidine infusion. Now, most likely this 2-year-old will need both morphine and dexmedetomidine. So again, the start low and go slow mentality applies here. And we'll talk about drug choice in a second. Why morphine? Why dexmedetomidine? So with the morphine, for example, often we'll just start the medication at some reasonable but relatively high dose. If this 2-year-old is opioid naive, a very little amount can go a very long way. So if you start the patient at 0.1 mg per kg per hour, guess what? They're going to need 0.2 mg per kg per hour tomorrow and 0.3 the day after. But if you start them at 0.025 or 0.03 milligrams per kilogram per hour, and then see what they need from there, you've committed them to a much lower dose from the get-go, and you have a much lower likelihood of opioid tolerance and dependence in the long term and needing to add all sorts of other medications to prevent physiologic withdrawal. So I would say for an opioid naive child, my personal choice would be morphine 0.025 mg per kg per hour to start, and a dexmedetomidine infusion starting probably at 0.3 as the infusion dose. And the reason for that is most people don't know what the adult FDA recommended dexmedetomidine infusion dose is. It's actually 0.7. And we've all seen doses that are much higher than that. As we all know, dexmedetomidine is an alpha agonist that actually has much higher affinity, approximately 16 times the affinity for the alpha-2 receptor compared to clonidine, for example. So that's why increasing dexmedetomidine doses significantly increases your risk of having dependence on that medication and needing to worry about weaning and withdrawal symptoms. So opioid and a sedative at the bedside, and my choice would be morphine and dexmedetomidine. But I'll see what questions you guys have about that or what you'd like to unpack there.
Yes.
So the first question that comes to mind, I mean, I think that locally I'm much more familiar with fentanyl dosing and using fentanyl early on in a patient's ICU course. I'm interested to know why you chose morphine, and maybe as a follow-up also, are you starting these infusions immediately after you intubate or are you waiting for them to wake up?
Great questions. So let's unpack fentanyl versus morphine versus hydromorphone. Those are 3 primary analgesic infusions that are easy to titrate and utilize. So the first question I always ask whenever someone suggests fentanyl as first line, whether it's in the ICU or in the operating room, because everyone loves fentanyl, is why fentanyl? Why is it the right choice in this specific circumstance? Fentanyl is the shortest acting opioid that we have, other than remifentanil, obviously, but we'll leave that separate. In terms of the 3 agents, it's the shortest acting. So my first question is always, why are we requesting a short acting medication? What are we trying to accomplish? So if you're starting a fentanyl infusion, my supposition is that you're probably not looking for something mega short acting, right? So unless it's a neuro ICU patient or someone that you really need to be able to turn off the strip instantaneously and wake them up and have a neuro exam that's completely coherent, you're probably not going to achieve much other than instigating chances of dependence and potential for withdrawal long term, because short acting medication, banging on these opioid receptors continuously to maintain a continuous plasma steady state level is just going to increase your risk for needing more and more fentanyl. Morphine is an awesome medication for many reasons. A, it's cheap. That's not the first reason, but it is cheaper than fentanyl. In addition to that, it's medium acting. It's in between fentanyl and hydromorphone, and it does have some sedating qualities as opposed to fentanyl, which people say fentanyl and use it as a sedative. One of my biggest pet peeves, fentanyl is not a sedative. It's a terrible sedative, and we should never be giving it with the goal of sedation. It's an awesome analgesic when you need short-acting medications. So morphine will give you a little bit more time and will require less medication potentially to maintain a steady state that achieves the analgesic goals that you're trying to achieve. And it's just a really great analgesic. It does a beautiful job. There's a reason in the emergency room, for example, morphine is often the first line for a supracondylar fracture or some random healthy kid that comes in. Why not take those same medications that we use first line as analgesia in those circumstances and use them for these healthy kids in the ICU in the long term? If I could design an NIH trial to compare the two and convince everyone that morphine's better, I absolutely would. I can only provide you my anecdotal experience that it works beautifully. In the operating room, same thing. Unless there is a very compelling reason to have a short-acting opioid on board, I use morphine almost universally for patients. Now, there are contraindications, really important to note. I don't use morphine in young neonates because their kidneys obviously haven't matured to the level where they can manage the metabolites very well. So, for example, morphine glucuronide can build up very quickly in infants and cause a prolonged state of sedation that you're not interested in. So that's really important to note.
Nice.
Do you see much pruritus, itching?
Love that question, and the answer is no. So I have not personally seen morphine-based pruritus. Some patients will come in, especially to the operating room, who have a history of pain and chronic pain issues, who say, I don't do well with morphine, I get pruritic, I get itching, and then we'll obviously use a different opioid in those cases. But they've done large studies looking at histamine release in oncology patient populations, et cetera, and the incidence of any sort of histaminergic related issue, including pruritus, is quite low and not a reason to avoid it. Maybe if there's patients with significant pulmonary hypertension, I would avoid it if the histamine release is a concern. But again, that's a pretty easy choice to make.
Oh, nice. Now, I have to ask, because, Zach and I just finished our PICU fellowship and we've done a lot of treating patients and reflecting on those patients. If someone's starting with the start low and go slow approach, what procedures, staffing, things do you need to have in place to prevent an immediate unintended extubation?
The most important thing to prevent an immediate unintended extubation is to prevent delirium. So believe it or not, infants, toddlers, and I know you two have both seen it, can be awake and alert and intubated with a breathing tube and not pull their tube out. Where things get unsafe is when they are not aware of their environment, they're inattentive and not lucid, and that's when the breathing tubes come out. So even though it seems counterintuitive or counterproductive to keep the patient more awake to prevent inadvertent or accidental extubations, in fact, keeping them wakeful is probably more likely to do so, right? Because you can imagine as you increase sedation, you're more likely to become delirious and not be attentive to your environment. And that's when things get scary. And that's when you are going to try to pull at all the tubes, lines, and drains that you have. So it's been really incredible to see the culture change happen. And when folks, I just was at the ESPNIC meeting in Rome and just talked very briefly about the start low, go slow mentality and morphine and dexmedetomidine as first line. And I got at least 10 emails, texts, direct messages on X, etc., from people from around Europe who had gone home and said, I tried this approach with this patient and told the nurses and the families what to expect, right? You can't just do this and be, peace out, I'm leaving the room. You have to do a little bit of counseling, education around the why. Why are we doing this? We're doing this to decrease the exposure of the brain to these medications. We're doing this to prevent delirium. And we're doing this so you can interact with your family member, with your child during a kind of stressful time for you and the child. It'll make them feel better to know that you're there and to be there. So that is actually the first thing. It takes a long time to impact that type of culture change because everybody loves a still patient, right? I always show that comic that says, when I'm talking about patient comfort and sedating to patient comfort, I'm certain they mean my comfort, right? So it's more comfortable to have a still patient. But you can make a huge change if you just take these steps to start low, go slow, and see what the patient needs.
And I think this is a better time for this follow-up question. Do you start these sedative infusions now, like immediately after you intubate them, or do you wait for them to wake up and then maybe bolus to start?
Yeah, you can start with the morphine, the dexmedetomidine at those low doses as soon as the infusions arrive, right? We all know it takes a while for the stuff to show up from pharmacy, and usually it doesn't come as quickly as you wanted to anyway. So I wouldn't hesitate to start the medications as soon as they arrive at those low doses because they're going to need something. And then if anything, if you really do want to see them wake up a little bit, I would at minimum start the morphine because it's that noxious stimuli of the ET tube, right? So no matter what, that's an uncomfortable feeling. No one wants to wake up to that feeling. So if you can try to take the edge off that and then assess what kind of sedation they need on top of it, I would say a minimum of morphine or some opioid, and then you can start the dexmedetomidine as soon as you think they're ready. Some people ask about bolusing versus just starting the continuous infusion of dexmedetomidine. I would say just start it at the low dose. Don't worry about bolusing because then you don't have to worry about issues like bradycardia and a hypoxic patient and all those other things that might come up.
Nice. So it sounds like in an ideal situation, after the intubation, as they adjust to the ventilator, they'll sort of wake up with stimulation, recognize their parents, easily calmed, and have a smooth transition to their mechanical ventilation. What do you do if you walk out of the room, you walk back into the room, and the patient is alligator rolling in the bed?
Has that ever happened before? No, of course it happens.
Not to imply that it would have ever happened.
No, it happens all the time, right? And that is the scenario that everyone is most nervous about is what if we don't have enough people in the room when that happens, especially in larger patients that, they're actually strong enough to get that hand up there and either pull the tube or lose the tube. So I would say that when that happens, obviously you need to manage the situation as best you can in the moment. And clearly that if you've already started the morphine and dexmedetomidine at the doses that I mentioned and they're alligator rolling in the bed, clearly the patient has demonstrated they need more than that, right? Or they need some other strategy. So I would use whatever you can in the moment to get them safe. And that might include, obviously, you could do a propofol bolus if it's appropriate, given the hemodynamics. Obviously, that's not a case where you want to give a big dose of honkin' dose of paralytic because clearly they're alert and they have some sense of what's happening. So I would say deal with it in the moment with a short-acting medication. If possible, please avoid benzodiazepine as your first line in that scenario because it's not going to make them be still immediately. So I think you just need to almost like provide a brief period of general anesthesia so you can take a step back and figure out what the best approach is. And if that patient's demonstrated they need more, then you escalate the doses, you give a bolus, and you try to find exactly what they need.
So maybe you get the sense for your patient, maybe you're a couple of days into the ICU stay, respiratory failure is persisting, you're anticipating several more days being intubated, you're not meeting your sedation goals, maybe they're closer to SBS +1, and you're worried about safety. How high a doses do you generally push these first line agents? And when might you add on a third or transition?
Excellent question. It's a complex thought process that needs to be had with the multidisciplinary team about what your goals are. So, like you said, Zach, this is a patient that you anticipate is going to be intubated for quite a bit longer, at least a few more days, if not several. So, I would say at that point is when you should be thinking about what is the risk benefit of continuing to increase my analgesic and sedative infusions versus starting background medications, right? And it's possible the patient's already on some background medication. So my typical approach is if I know a patient's going to be intubated for longer than 7 days for sure, like there's no question, maybe they're post-op patient and they have some post-op needs, or you just know this is severe ARDS and this is not getting fixed in 5 to 7 days, then it's not unreasonable to go ahead and start the backgrounds earlier in the mix. So I personally utilize enteral medications as much as possible. Again, the theme here is going to be what can you do to normalize things as much as humanly possible in this crazy situation that is totally not normal in any way, shape, or form, but use the gut, right? So obviously, this is not a podcast about nutrition, but anything you can do to keep that gut moving, especially if they don't have any GI issues to begin with, is important. So I actually use enteral methadone early in a long-term intubation patient's course. And also, and I know I said no benzos, but when I say no benzos, I'm specifically speaking to IV benzodiazepines. So enteral diazepam works beautifully to create a background kind of steady state enterally to take that, maybe that additional edge off that will help to smooth things out. So with enteral methadone, I would start at 0.05 mg per kg per dose, Q8 hours. And I would obviously check your EKG and do all the things you would typically do before administering methadone. And then for diazepam, I would start at, it's similar dosing in terms of midazolam. So just pull out your cards and start at the lowest dose possible, and then dose that at Q6 hours. Now, you don't have to start both at the same time. You can start, if you think analgesia is more of the issue or challenge, then do methadone. Again, if you think sedation is more of the issue or challenge, or maybe anxiolysis is needed, then I would go with the diazepam. But the intentionality around the medication choices and classes is really important. We recently published a study in the Joint Commission Journal, actually because we got cited because we were administering PRNs for things that weren't actually the reason that they needed the medication. So for example, a benzo was being given for analgesia, or an opioid was being given for sedation, when the nurses were just trying to do the right thing and keep the patient safe. So we created an order set that specified exactly what medications are being given for what indication, and that has worked beautifully for us in terms of our overall sedation and analgesia strategies.
Nice.
So if I'm understanding correctly, ideally you would want to start these enteral medicines before you would start a third line IV agent.
100,000%. Yes. If the gut is working, use it, because all you're going to do with another infusion, right, is to facilitate potential dependence and increases in another continuous infusion that may or may not need to go through a central line. It may or may not need to. There's all sorts of other ramifications, right, in terms of access points, IV infiltrations, all the things that you guys know very well are additional things that we haven't even mentioned. Anything you can avoid putting in IV is always best. And I find that 95% of the intubated patients I take care of do just fine with 2 infusions, 1 sedative, 1 analgesic, and background enteral medications. And if for some reason you can't use their gut, then you can always give the diazepam and or the methadone as an IV medication. But
Nice.
bolus, right? Not a continuous infusion.
So maybe a dissenting view. So, you have this patient who's very agitated now. And I do recognize that enteral strategies probably is better long-term, but I would imagine you're going to need multiple hours to get the steady state of these enteral medicines. How would you typically bridge that patient to safely to where those enteral meds are at their steady state? Would you add on a third agent? Would you give bolus dose ketamine? What would you use?
Yeah, I would actually, again, every situation is so different, Zach, as you're suggesting. So I would start with the infusions I already had at the bedside, right? So if I can give a nice bolus of morphine, or even if you need a dexmedetomidine bolus at that point, if you're truly unsafe and you need something quickly, then yes, you should give a bolus of ketamine and kind of find and again, I personally, and this question always comes up, I personally would give an IV ketamine bolus before I would give an IV benzodiazepine bolus. Because ketamine, believe it or not, ketamine is actually less deliriogenic hypogenic than an IV midazolam bolus or infusion because it's a short acting, it's a beautiful drug, and it has analgesic qualities unlike midazolam, right? So the ketamine can kind of accomplish multiple things in the interim if the patient's unsafe. You just got to do what you got to do if you can avoid benzo. Now, there's really very few indications for giving a benzodiazepine in that moment or starting a midazolam infusion. But I always remind people the goal is not to walk away from this and say, Sapna said benzos are bad, I should never use them in the unit, right? So there's 3 very important indications for benzodiazepines, and that's seizures, spasms, and spasticity. So if any of those things are part of your mechanically ventilated patient situation, please, by all means, use benzodiazepines as needed in those scenarios. However, if you don't have any of those things, then I would say opioid and dexmedetomidine with additional adjuncts as needed to keep the patient safe, including ketamine and propofol. We haven't touched on propofol yet and its use in the pediatric ICU. We all know we're all deathly scared of propofol-related infusion syndrome. But remember that propofol-related infusion syndrome is highly correlated with the duration of the medication administration and the dosage of the medication. So a tiny bit of propofol could go a long way to help you bridge until you figure things out. And again, it's a wonderful medication for that purpose as well. And, if you start at 10 mics per kg per minute or something like that, that's probably not going to hemodynamically impact your patients substantially. And it might just give you exactly what you need until you get these backgrounds under control.
Oh, awesome. I love the idea of just a little bit of propofol in the background.
Just a touch, just a tiny touch. And again, you need to keep track of how long it's been on and what you're doing and all the things. But, then if you're doing like 10 or 15 or 20, right, you don't have to worry about the lipid levels. There's all of those other things don't become as big of an issue, and you're highly unlikely to have a lactic acidosis. Now, don't use it in patients with mitochondrial issues, stuff like that. But, and again, this 2-year-old, I'm going to assume relatively healthy kid, it's probably fine.
Oh, yeah. One final question about the enteral agents. How do you prefer diazepam to lorazepam specifically when you're choosing an enteral?
I got that question at ESPNIC actually, because some units don't have diazepam, some don't have enteral lorazepam. So I think either are fine. I like diazepam, it just tends to be a little bit longer acting, and we have it easily accessible here in our unit. So I think either are fine. They're both better than midazolam. And so just to give you some perspective, I've actually moved away from giving preoperative midazolam to my healthy operating room patients before anesthesia unless absolutely necessary. If they have an IV or they have a nose, I'll give them intranasal dexmedetomidine or IV dexmedetomidine if they need it, but non-pharma approaches work beautifully. And I think we haven't talked specifically about that, but if you have access to child life specialists, if you have these folks who are just really good at non-pharmacologic intervention, it really goes a long way at the beginning. Once the train's left the station and you've schnockered the kid with all sorts of stuff and they're delirious to beat the band, none of those things are going to help very much, right? So that's why this very intentional first 24 hours is key.
Oh, nice. Ooh, I also have to ask, what about when you're intubating someone? What if you're intubating someone and you really don't want them to remember it?
Yeah. So that's as opposed to after intubation during mechanical ventilation, where it's okay to have the patient aware and alert and know what's happening in the ideal scenarios. However, for intubation, we all don't want anyone to remember being intubated, right? That's very clear that you need a patient well anesthetized, not sedated, well anesthetized for the act of putting this piece of metal in their mouth and sticking a tube in. So the key here is, I was trained in pediatrics as a resident, and I remember every kid who got intubated always got fentanyl and midazolam. That was the go-to pediatrician's choice for intubation. And if you think about those 2 medications and have listened to the first part of this podcast, hopefully you've taken away that that's probably not the ideal combination for any sort of intubation, right? Because yes, you are likely achieving some analgesia, and yes, you're likely achieving some amnesia. But again, those 2 medications together are hard to predict in terms of what you're actually achieving. Are they going to remember? Are you achieving enough pain control? Especially if you're giving paralytic right after, it's an RSI situation. So what I train my residents and fellows is basically you have 3 primary agents to go with. You have ketamine, propofol, and etomidate. Those are the 3 medications that we know consistently will provide you with the level of anesthesia that you need to put in the breathing tube with typical doses in every patient. Now, remember that not you guys remember, but everyone listening should know that propofol, a little can go a long way in a highly critically ill patient. We try to avoid it when patients septic or hemodynamically unstable. Ketamine, again, is a beautiful medication for almost every single type of intubation. I say almost every single type because it may be contraindicated in some, but giving ketamine of 3 per kilo in most children will achieve what you need in terms of sedation, and also has analgesic effects. And so you don't have to worry about giving multiple agents, and then you can comfortably paralyze the patient if paralysis is part of the plan. So I love ketamine. It's analgesic, and it's a bronchodilator if that's what you need. Like, there's so many things it achieves. Just remember that it's a sialagogue, so you will have to deal with that if that becomes an issue.
Nice. Thank you.
Absolutely.
I think this is a great little tangent. Maybe put a cap on with this question here. So it seems like 3 per kilo ketamine is a good dose. And I wonder about your strategy when you're intubating a critically ill patient. Do you give ketamine, assess your level of sedation, then give paralytic, or do you rapid sequence?
Yeah, that all depends. I think we could do a 2-hour podcast
yeah.
just about that, right? And then put on my anesthesia hat. So for me, right, I have my healthy kid coming in for a hypospadias repair in one side of my life. And then on the other side of my life, I have the kid who's falling apart and hypoxic and hypotensive. And so for that latter patient, right, again, anytime you're doing intubation medications, you need to make sure it's titratable and easy on, easy off, potentially, and also dependable. You can predict what's going to happen as you titrate the medication. In the PICU and in the ED, we probably do many more RSIs, right? Because these are often traumas that come in. We know their full stomachs, et cetera. In the PICU environment, when you have a hypoxemic patient who needs to be intubated, assuming they don't have a full stomach or a functional full stomach, whether it's massive ascites, et cetera, if you can avoid an RSI, that's nice, because then you can provide them the oxygenation they need during the period of time that they are being paralyzed. I do encourage people to use paralytic for every intubation, unless, of course, it's a mediastinal mass or some other pathology that requires spontaneous ventilation throughout in order to not burn a bridge. But if you're not going to burn a bridge by giving paralytic, I would almost always do a titration approach. So start with 1 per kilo. If the 1 per kilo doesn't work, give another 1 per kilo. And then if they seem adequately anesthetized, you can go ahead and push your paralytic and do the intubation. But if you're doing an RSI, because an RSI is indicated in this case, then I would do a minimum of 2 per kilo of ketamine. Be ready with your phenylephrine and volume and all of the other things that you might need if they're catecholamine deplete and all the things we talk about when we do teaching sessions on this, and then push the rocuronium. And don't forget about succinylcholine. I know in the PICU, a lot of people are scared of this medication. I used succinylcholine 5 times in the last 2 days because I had 3 traumas and 2 other kids who just needed to be intubated instantaneously, right? And Sux will provide you the intubating conditions you need faster than anything else. So we love rock. It's an amazing thing, but think about whether Sux might be a better choice as long as you have someone who's comfortable using it.
Nice. A helpful aside. Let's get back to our case. So remember, you have our 2-year-old with respiratory failure, intubated, pneumonia. Maybe we're 3 or 4 days into the ICU stay. We've been going up on our morphine, going up on our Precedex judiciously. We have our background methadone and Valium kind of in line, getting into steady
Strong
state.
work. This is a good approach. I like it.
Yes.
I like it.
An expert-driven approach, actually.
Yes, that's fantastic.
And the nurse is diligently giving us a call every hour. We feel like our patient's not really responding to the PRNs. We're starting to get the sense maybe we're not dealing with agitation. We're not dealing with pain control. Like maybe this is delirium. And a 2-year-old, it's really tricky to get an idea. Are we dealing with delirium or not? And I'd like to know, what's your approach to actually diagnosing delirium in a toddler?
Great. So delirium, as you all know, has multiple signs and symptoms, but you don't have delirium if you don't have inattention. And if you're attentive, you don't have delirium. So bottom line is inattention is the key. And the only way to truly assess that in a 2-year-old is to use a validated screening tool for delirium. The good news is most of our units across the country and many units across the world are starting to use these delirium screening tools. and trying to do it more consistently. We just published a paper in PCCM that's hot off the press from this month that showed that among 6 units that say they use delirium screening tools consistently, they only actually are screening those patients approximately 50% of their PICU days, right? So the key is consistent screening and obtaining a baseline. So I'm going to assume, Zach, for all intents and purposes, given the sedation approach has just been so spectacular, that this patient has been being screened from day 0. The other thing that we learned from this study is that we do a great job screening after like day 4 to 5. But from day 0 to 5, it's very willy-nilly and decreased a rate of screening. And why is that? Because we're all focused on the resuscitation, the hyperacute phase. And then once the things have stabilized, we're like, oh, maybe we need to do these typical practices that are recommended. So key is screening from day 0, because, for example, if you're using the CAP-D, the Cornell assessment for pediatric delirium, which is what the majority of units in the United States use, if you have a score of 10, that might be concerning for delirium by the relative standard. However, what if the patient was a 9 on the day of admission, right? What if they have some developmental delay or some baseline issue that would cause their score to be higher to begin with? So then you need to take the score in context. So that's really important. So first, what I would do for this 2-year-old, let's say their day, did you say the day? Day 10 of their hospitalization, they're delirious. So I would look at what was happening on day 9, A. I would talk to their family. The family knows them best, and ask them what they think, right? Often families will detect their child is delirious before we actually detect it using any of our tools, because they just have that additional sense of who their child is and how they act. And that's whether they're intubated or not. So I would say look at the score from the day before, A, using a validated screening tool, and then assess them for attention. At Hopkins, we use the pediatric and the preschool confusion assessment method, or PSCAM or PCAM ICU. It's built off of the CAM ICU in adults. The reason we use that is because it has an objective assessment of inattention. So there's some great videos on icudelirium.org where for older children, you're asking them questions. For younger children, like this 2-year-old, you're using picture cards. And basically, are they following the picture cards? They're brightly colored. And then if they are positive for delirium, then you have to figure out how to address it. But again, it's in the context of what their baseline is. And that applies to obviously mobility as well, right? Like everything that we do has to be based on the patient's home routine and their baseline.
Nice. So now that you've identified this patient as delirious well into their hospitalization, I'm curious what your acute approach is, because there's this spectrum of early mobilization. And on one hand, you could make the environment more like home. You could do what we did in med school on internal medicine and pull down the curtains at night, open them during the day. You know, you can do all of the other things. On the other hand, you could put that toddler on a trike and send them down the hallway. So what's your acute approach, and what's safe when the patient is actively delirious?
Yeah, the key is what you said is what is your acute approach? So then same thing, had to be intentional about how acute is this? Now, it's interesting. The majority of children that are delirious in our intensive care units aren't the agitated, hyperactive delirium that we are so familiar with and want to treat acutely. They actually have hypoactive delirium. So they're the kids that are just laying there and are inattentive. And they often are the easy patients, which is why it's really important for us to screen, because those kids can have downstream effects in morbidity and potentially mortality as a result of it. But let's, for all intents and purposes, assume this patient is acutely agitated and inattentive, and they are somewhat unsafe. And there's a concern about tubes coming out, et cetera. And we all know the tube's more likely to come out if they're delirious. In that situation, non-pharma approaches are awesome, but hopefully you were already doing them in the first place. You avoided benzos, you had the shades open, and you were doing all the things else that you just mentioned. So in that case, we have shown through multiple studies that antipsychotics in the acute phase can be safe in children. And so I think being intentional about choice, if they're truly unsafe, haloperidol has been used in critically ill children with success in a hyperacute unsafe situation. If it's more of a insidious, there's intermittent agitation, they're clearly delirious and we have to address it. If you don't have access to child psychiatry colleagues who are well-versed in ICU delirium, you can provide some low-dose risperidone or quetiapine as the 2 primary medications that have been tested for safety in children. Again, they're not FDA recommended or used for these specific indications, but we use them commonly. And the dose is really important, starting low, going slow again, right? Because you're just trying to do enough to create an environment of safety so that you can progress with the non-pharmacologic approach. And also, more than anything, while you're treating and keeping the patient safe, Zach, for example, Alice, you need to be looking for what are the iatrogenic and organic reasons this child may be delirious all of a sudden. So one of my favorite cases to share with trainees is the patient who was negative for delirium over 3 days, and all of a sudden they're positive for delirium. And then 6 hours later, their blood culture comes back positive, right? So delirium is just like pain. It can be a fifth vital sign or sixth vital sign, whatever you want to call it. Delirium can be telling us that something else bad is going on, as opposed to, oh man, you just threw the kitchen sink at me and I have many reasons to be delirious. So I think that can be our end result in diagnosis, but you have to rule out the bad things first. And that becomes really important. But you also have to keep them safe in the moment while someone's trying to figure that out.
Yeah, as an aside, I think maybe fundamentally delirium can be described as acute brain dysfunction, and
absolutely,
it's like any other organ dysfunction. It could be a marker of something bad systemically happening. So, keeping that in mind, that your patient's worsening from a delirium standpoint, there could be a broader systemic cause.
That's beautifully put, Zach. And I think it's really important to not just throw antipsychotics at it if you don't know for sure that there isn't some other reason for that acute brain dysfunction. And like I said, if they have a reason to be infected, if they have a reason to have a brain bleed, like whatever the thing may be, you need to investigate that. And there's many mnemonics to figure that out. The most comprehensive is I watch death, because it's easy to remember. And it literally runs through like every single potential thing that could be wrong in the ICU. But Dr. Dre is a good one if you want something shorter. And Dr. Dre gets into, disease remediation, drug remediation, all those things that you should be thinking about on a broader class-based level.
I have one follow-up question about antipsychotics. So perhaps you decided, you diagnose the patient with risperidone, and the clinician decides that they'd like to trial antipsychotics to manage their, whether it's hyperactive or hypoactive delirium. I guess the first question would be, do we feel like antipsychotics actually improve or shorten the duration of delirium? One. And what do you titrate these doses to? So if I have the patient who's hypoactively delirious, who's potentially not in acute danger to themselves, what does a antipsychotic offer for that patient?
Excellent point. Almost always with hypoactive delirium, it's most likely going to be iatrogenic. With hypoactive delirium, it's going to be a state of either oversedation or polypharmacy that's been provided by us that's created that state. So probably the best thing and most important thing to do is start to peel away slowly the stuff in the background that may be causing it, right? So maybe you skip their next dose of methadone, or you decrease their infusion doses if they're already high. And then the very low dose of antipsychotic could be just enough to improve their state in that scenario. But you're absolutely right. Hypoactive delirium is a little harder to titrate to because you don't have any active behavioral signs. You're watching to see that they actually become more wakeful and alert as a result. So I would be very careful about increasing antipsychotics without a psychiatrist's input in that scenario specifically. And to be honest with you, if you're in a highly resourced unit that has access to child psych, they may or may not be very comfortable with ICU delirium stuff. And in our unit, actually, we worked with our psychiatrists because they are the experts in the DSM-4 criteria and DSM-5 to actually diagnose. It's just in the ICU environment, it's a little different. So we got our psychiatrists on board with doing their own training and education around our ICU delirium screening tools. And our pathway is actually, in addition to non-pharma interventions as first line, if it's not a Haldol right now scenario, to call our child psychiatrist to come do an evaluation, look at all the other meds the kid's on, and help us dose and pick the class of drug or the type of drug, because risperidone may be better than quetiapine for some patients because of the other medications that they're on or their underlying diagnosis. So I wasn't trained in those medications, right? And neither, we just learned by experience. The other really important reason to integrate child psychiatry, if possible, what's going to happen once the kid leaves the unit, right? So often the kids get discharged on these medications if someone wasn't intentional about weaning them.
Oh,
I don't know about you guys, but I'm not an expert at weaning those medications. So someone needs to follow them. And generally child psych is the group to do that.
yes.
I think we would all recognize, having that multidisciplinary team is best for the patient. And gosh, I mean, pediatric psychiatry would be a great resource. I imagine, though, that many of our listeners won't necessarily have access to those, especially in the ICU.
Right.
And I think I'd like some insight into what is a fair dose of antipsychotic medicines. And practices patterns that I've noticed are maybe 3 days of antipsychotics at night. I've also seen, nightly plus a PRN during the day. In your practice, what do you consider as a fair trial of these medicines?
Great question. So in terms of duration and trial, I would say if you can even do one dose, I wouldn't start them on standing medication unless absolutely necessary. Now, if it's a patient that's been in the unit for 2 weeks and you're going to be intubated for another 2 weeks, or then it might be worthwhile to start a QHS situation, right? Just a little dose at night. But overall, I would say for the short-term patient, one dose may be enough to just get them back on the day-night pattern and cycle that kind of smooths everything out. I would say 3 days is probably the longest I would do for that short-term patient, especially if let's say they were day 5 of 7 of intubation. You should be pulling that stuff off by day 7 so that they can get extubated and not be committed to the medication long-term. And you also have to think about talking to families about the medication, right? Because often people have, and this comes up with methadone as well. We haven't talked about this, but whenever you start bringing up drugs like methadone or antipsychotics, there's a perception associated with that. So it's really important to share with families, when appropriate, that this is why we use this medication. It's not, for the typical indications that the lay public have heard of these medications. We're using them to optimize your child's outcome and make them feel better.
Nice. You touch on an interesting point with your involvement of the psychiatrists that in the ICU, we diagnose and treat delirium, although we are not psychiatrists. And then when the kid goes out to the hospital floor, it can be difficult, right? Like they don't have the screening
peace
tools.
out.
They don't have the stuff.
Exactly. Yeah. That's an area I think for growth. It applies to everything about the PICU Up program as well. Like we do all the stuff in the ICU. And then like what happens when they go to the floor are we doing floor-based activity mobility promotion? Are we doing floor-based delirium screening? I'm sure there are kids on the floor who are delirious, right? But again, we're not following those patients. So I don't know how many of our general pediatrician hospitalist colleagues are listening, but I think it would be a great opportunity for this type of work to be carried through to the floor setting so that we can make sure we're addressing it in those environments as well.
Oh, yeah.
Wow. Shall we transition to the early mobility questions?
Let's do it. Your patient is on a PEEP of 8, 40%. You're hoping to extubate by the end of the week. Your resident follows several pediatric leaders on X, the social media platform formerly known as Twitter. He's seen photos of young children participating in many activities while intubated and asks if this patient would be a candidate for early mobilization. So as the attending of record, what mental checks are you doing first to consider whether you would mobilize this patient and how much you'd mobilize this patient?
Well, first of all, this resident's getting the best evaluation known to anyone or that I've ever given anyone in my life. No, so I love this resident's question, obviously. And so what I would tell the resident and the team is fantastic. Let's think about this, right? So whenever we talk about the term early mobility, the first thing is, what does it mean? And it's important as you're trying to establish a culture of early mobility in your own unit to make sure that everyone understands that it's a very wide spectrum. And it's based on the patient's baseline developmental abilities, what they did before they were sick, and also what is okay to do in the setting of the acute illness. And then finally, and this doesn't get talked about enough, is pragmatically what's possible in the setting of what's happening in the unit. Right? So let's say your unit's completely full and there are like 4 or 5 kids who are like on ECMO watch and the unit's just a disaster. That's probably not the day to do the first mobilization event for a highly critically ill child. But let's say it's a reasonable day in the unit. We don't have many post-ops and things look good and everyone's feeling good. That's when I would say, okay, well, let's think about what the best mobility option is for this patient based on what's happening with their lungs, et cetera. So how much oxygen was this kid on? Again, 40%?
40%.
Oh, great. So the kid's probably going to tolerate some mobility. My question is, what have we done so far, right? So far, all the child's done is have their head of bed at 30 degrees. Then I would say, hey, hopefully we had consulted our physical and occupational therapy colleagues by now to do an assessment. And this resident's clearly on top of it. So PT and OT have come by, but unfortunately they've been sent away a couple times because the child was too sick to mobilize. So we'll get to what that actually means. The people on listening can't see my air quotes, but what does quote too sick unquote mean actually? So I would ask my therapy colleagues to come by and say, hey, what do we think this child could feasibly do? Now, let's say your physical occupational therapy colleagues aren't immediately available. If you have a nurse who's experienced and feels comfortable with the breathing tube and a respiratory therapist who's willing to be at the bedside, there are things that we can do without having PT or OT immediately involved, i.e., having mom hold or dad hold the patient, right? This is a 2-year-old. So often the highest level of mobility is therapeutic cuddles. So that's, it's a hashtag. This resident would appreciate that. Hashtag therapeutic cuddles. And I love that this kid's too, because often we don't even ask the question to the family of, do you want to hold your baby? Do you want to hold your toddler? And what would make that toddler happier than anything than to be hugged by their parent, right? Or to be loved by, or to have that positive touch. So I would say, what do we think? Do we think mom or dad wants to hold today? Can we make that happen? We ask the nurse, and then we help the patient get moved to the chair with mom or dad. I actually got to watch that happen yesterday for a child who had been in the unit for 6 weeks exactly and had not been held by their mom.
Wow.
And often there's a lot of worries around that, right? Are they going to be unsafe? Is the tube going to fall out? Are they going to be more agitated? I'll never forget the day that I asked, it was actually a 2-year-old. I said to everyone on rounds, why don't we get them out of bed with mom today? Why don't we do that? And everyone seemed a little nervous because the kid had been quite labile over the last several days, but was requiring more and more sedation actually. And so everyone's like, I don't know, is this going to work? I said, well, if we think it's unsafe, we're not going to do it. But if we think we can make it work, let's try. So I walked away and rounds were finished. And an hour and a half later, the code bell went off in that room. And of course, in my head, as I'm running over there, the fellow there before me, I'm like, oh man, gosh darn it. Like I convinced the team to do this and it didn't go well. The reason the code bell was hit is because the patient's heart rate dropped by 30%. And it wasn't for a bad reason. It was because the patient was comfortable again. And she had been agitated in her bed for so long. And who knows, maybe we should have moved her earlier, right? Gotten her to mom's arms earlier. So that's what I would say to this resident is, well, let's make sure physical occupational therapy are involved. But in the meantime, let's see if we can get this kid out of bed to mom's or dad's arms to be held. And that's probably the best mobility for that kid. If they walk at baseline, if this is a 2-year-old that's walking, then we can think about dangling at the edge of the bed, etc. But while we wait for PT and OT to help us with those more advanced things, I would do the basic thing, which is holding.
That's beautiful.
I think so.
Yeah. Well, just thinking, like reflecting, I have a 2-year-old child, and
yeah, okay,
and she's beautiful, young toddler.
Of course she is.
And gosh, if she was sick, first my whole world would be wrecked. But the best way as a dad that I could imagine supporting her is me holding her, or my wife holding her.
Yep.
But then I put on the physician hat and I think, all right, we need morphine and dexmedetomidine and methadone and Valium. For some reason, when I put on, scrubs and white coat, whatever, like that humanism gets pulled from me. And I think early mobility, delirium screening treatment, it's kind of that aspect of humanism kind of bringing us back to this grounded spot. And I think that's why this is such an important topic to discuss and share with our listeners. And we appreciate this message.
Well, can I take you on the road with me to share exactly that perspective every time? My entire career was established around this entire ICU liberation, PICU Up. And, it's not sexy stuff. Like, it's so common sense. It's embarrassing, right? Like, okay, children need to have good nutrition. They need to sleep well, and they need to play, and they need to be loved. Those are like 4 basic tenets of childhood. And Zach, your daughter, obviously experiences that every single day. And so when any child gets critically ill, unexpected or not, you're right. Why does that all of a sudden all go out the window immediately and then only get considered once things start to get better again? We're losing a lot of opportunities early in admission to address not just humanism, but the basic physiologic needs of a child. And love is one of them, right? And touch is one of them. And just think about the number of times people come into that 2-year-old's bedside and do things or touch them or do things to them without talking to them, just because they're on sedation, right? We interviewed a 16-year-old for the ICU rehab conference last year. She was very clear that she appreciated being awake and alert when she could be, but one of her major complaints was that she felt constantly violated because people would come into the room and whether it's consultant, PICU people, whatever. And just because her eyes were closed, they would assume she was sedated and they would just start doing stuff, examining her, et cetera. And how would that feel to anybody, right? And so little ones feel the same way as a teenager. Everyone wants control, whether we like it or not. So giving teenagers more control, giving children love with cuddling and all those things, it's not sexy, it's common sense. And if I can spend my whole career talking about these common sense things, that's fine. I'll do it. But I think we just need armies of people promoting that and thinking about it. That's why I love Child Life, because that's their MO. That's what they do. And they have play specialists in Europe and Australia, and obviously low resource settings don't have the resources like that, but they actually sometimes do a better job because they recognize that they don't have the high tech stuff. So they need to focus on the low tech.
Oh, well, that's wonderful. Thank you so much for sharing your clinical approach.
Absolutely. My pleasure.
Thank you for listening to part 1 of our 2-part series with Dr. Kudchadkar. Next week, we're going to talk with her about how she transitioned from an extremely clinical career plan to really writing that first R01 and getting it funded. And thank you for listening to this episode of Peds Crit. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as a replacement for medical advice. It's also worth noting that the views expressed during this episode by me, Zach, and our guests are our own and do not reflect the official position of our institutions. If you have any comments, suggestions, or feedback, you can email us at pedscritpodcast@gmail.com. If you want to help support the production of Peds Crit, you can find us on Venmo and Patreon. We've also had some light merch made in the form of Peds Crit laptop stickers, and if you include a mailing address with any contribution, we would be so excited to send you one. Thank you again for listening.